The use of post-transplant cyclophosphamide-based regimens to prevent graft versus host disease is one of the biggest advances in transplant over the last 2 decades. Popularized by our colleagues at Johns Hopkins, it was first shown to be effective in haploidentical transplantation, the ability to engender engraftment as well as prevent graft versus host disease in the setting of a half-matched related donor has been remarkable. And post-transplant Cytoxan has emerged as the standard platform to conduct haploidentical transplantation. As this success was observed and then also generalized to many centers across the country and the world, it was only natural to expand this platform to other transplant settings. At Mass General Hospital, we standardly use this platform for all of our haploidentical transplants. We have now started to use post-transplant Cytoxan for our mismatched unrelated donor transplants as well. The recent registry study from the EBMT would suggest that these results using the post-transplant Cytoxan for mismatched unrelated transplants are superior to what we've used in the past, confirming our practice. Recently, clinical trials have also been conducted comparing post-transplant Cytoxan to our standard regimens that we've used for conventional transplants, such as match-related or match-unrelated transplants. BMTC TN 1203 was a 3-arm trial in the reduced intensity setting that compared 3 new regimens, including post-transplant Cytoxan, to a contemporaneous registry control of our standard tacrolimus and methotrexate. The post-transplant Cytoxan platform was the only one of those 3 regimens that suggested superiority, and the BMTC-TN has now moved into an ongoing phase 3 trial comparing these 2 regimens, specifically post-transplant Cytoxan, to our long-held control of tacrolimus and methotrexate. Similarly, at this ASH, the Dutch Hovan group will present an abstract on Sunday showing the results of their randomized trial in about 150 patients in the reduced intensity setting, comparing post-transplant Cytoxan regimen to the control cyclosporin and mycophenolate mofetil. Their results suggest that patients who receive post-transplant Cytoxan have benefits not only in the prevention of severe acute and moderate to severe chronic graft versus host disease, but long-term have a superior graft versus host disease relapse-free survival, the composite endpoint that many of our trials are based on right now. We look forward to the long-term follow-up for that study as well as the results of the BMT-CTN study. One of the abstracts that we're presenting here involves a small series of 9 patients, but we felt it was important to include. These 9 patients actually do not have hematological malignancies, but have non-malignant hematological diseases such as aplastic anemia, PNH, or diamond black fan. And these patients will often need hematopoietic cell transplantation, and these are the patients that we want to prevent graft versus host disease in the most because they do not benefit from any graft versus malignancy effect. Several years ago, we read the exciting reports out of Johns Hopkins. They had published their early experience in aplastic anemia, and we adopted the use of post-transplant Cytoxan for our non-malignant hematological patients as well, given that post-transplant Cytoxan appeared to be the most potent regimen we had to prevent graft versus host disease. Our 9-patient series showed remarkable and compelling safety. All patients had full donor hematopoiesis and very, very limited graft versus host disease. And patients who were after 12 months, all were off systemic immunosuppression. And this has become our standard for that subset of patients. In the future, we look forward to the results of the large trials comparing post-transplant Cytoxan to our standards to see if this might become our new standard moving forward.